Well, good morning. Thank you very much for joining us this morning. We're going to learn about advances in laboratory testing for coronary heart disease, and with a clear focus on the new plaque test for lipoprotein-associated phospholipase A2. As you probably know, or many of you will learn, as I will as well, about how Lp(PLA2) is produced. And actually, in clinical chemistry, you know, there's two ways that we can measure proteins. There are probably others, but two major ways. One is as a mass assay. And what a mass assay does is we know that all enzymes are proteins. And so we measure during a mass assay, we treat the enzyme as if it's a protein, okay? So we have immunoassays that we can develop. We developed antibodies to Lp(PLA2) and can measure it in what's called mass units. The other way is to treat the enzyme like an enzyme, right? Its ability to take a substrate to a product, and so we can follow that generation of a product to quantify this enzyme. So this is what we're going to learn about today. That there's a new way of looking at Lp(PLA2), and we will have several discussions on this point. Our objectives are shown on this slide. We hope to meet all of these objectives, and for this purpose, we'll have three speakers, and I will moderate this session. I just wanted to bring your attention to this clinical portal that has a great deal of information, very well done scientifically, that's at the website shown here. And this will be on I believe this will be available for you after the talk or during the talk on those sheets that were on your seat. So you'll be able to visit this portal yourselves in your spare time. What I'd like to do first is introduce a colleague, Dr. Peter McCullough. Now, Dr. McCullough got his MD degree from University of Texas Southwestern University Medical School. He graduated at the very top of his class. He's a member of the Alpha Omega Alpha fraternity. He did an internal medicine residency at the University of Washington in Seattle. He did a cardiology fellowship at William Beaumont Hospital, and during that time, he managed to get a master's in public health at University of Michigan. Currently, he directs the cardiovascular education and research for Baylor Healthcare System. He's also vice chief of medicine at Baylor University Medical Center in Dallas, and is also on the faculty of Texas A&M. Dr. McCullough is prolific. He has over 1,000 publications. He also maintains a lot of editorial activity in the field of cardiorenal disease. He's the chair of the National Kidney Foundation's Kidney Early Evaluation Program, which is a great public health service. And Dr. McCullough is going to talk to us about Lp(PLA2) as a marker of vascular inflammation and coronary heart disease risk assessment. Thank you, Peter.
Well, good morning, and thanks to each and every one of you for attending this symposium. I do have to comment, as laboratory directors, I'm really amazed at how early you get up in the morning and you dig in on the data with breakfast. As introduced, I'm an internist and cardiologist at Baylor in Texas, and our CEO of our health system, we're the largest health system in Dallas, or actually in Texas, soon to be outside the borders of Texas, the Baylor Scott and White system. Our CEO, Joe Allison, has in our mission statement at Baylor that our pathway to progress in healthcare is going to be personalization of medicine. Personalization of medicine, that is, using tools that help us identify differences, unique differences among individuals in order to focus therapy. And we're seeing this happen now with molecular diagnostics in cancer. We're seeing this happen in other fields. And he believes, as I do, that personalization of medicine will be the next big leap forward in the improvements in healthcare, that we won't have broadly applied therapies, but they'll be very focused based on profiles, clinical profiles. And our main tools for personalization will actually be more use of the laboratory and advanced laboratory measures and probably advanced imaging measures, radiographic and ultrasonic, other forms, magnetic resonance, other forms of imaging. So personalization of medicine, I think, is going to be a big theme. You're going to hear a lot more about it. The other big news in preventive cardiology is on Monday, the commercialization happened. The FDA approval occurred Friday, but the commercialization Monday of monoclonal antibodies against PCSK9, proprotein convertase subtilisin hexin 9. This is a protein that interferes with LDL breakdown or LDL receptor recycling and helps facilitate LDL receptor destruction. PCSK9 monoclonal antibodies have been approved broadly for use in lowering cholesterol for patients. And you're going to see this. It's big news. It's expensive therapy, but it is in addition to maximally tolerated statins. So with that, I'm going to focus in on, I think, a tool that really is along the lines of personalization of medicine, and that's lipoprotein-associated phospholipase A2 as a marker of vascular inflammation and coronary heart disease risk assessment. This is a tool, an immunoassay that's been available for many years through specialty laboratories and now will be broadly available, but as an activity assay in big laboratories like yours across the country. So I want to make a few points with respect to lifetime cardiovascular risk. It's always kind of interesting to think about this and what can be achieved in cardiology. And that if we were to look at our lifetime risk of cardiovascular disease, you personally, me personally, what do we really know from large studies? Well, in fact, individuals who have, men and women who have 2 or more major risk factors face a lifetime risk of about 40 to 50% over the course of our life of a myocardial infarction or cardiovascular death. And then you can see here these lines, and the teaching point of this slide is that when you get down to green, where all the risk factors are optimal, that one has really a giant reduction in cardiovascular risk over the course of one's life. About anywhere from 80 to 90% risk reduction with perfect management of risk factors. You can have them, but they have to be managed. And this gives the idea that atherosclerosis is a multifaceted illness. Cholesterol is one piece of the puzzle, but there are many other pieces, and so there's a real hope that we could actually manage that green line down to really a negligible level. I personally plan to never have a heart attack or face cardiovascular death. I personally plan to never have a heart catheterization. That's kind of my goal. Why should I? It's preventable. And in fact, myocardial infarction in the United States is on the way down. Coronary artery bypass surgery has plummeted in the United States. Coronary artery stenting is way down. We are making major progress in cardiovascular disease, in part because we have advanced tools. So just a quick primer about lipoprotein-associated phospholipase A2. Most of you have not run this assay in your lab, so it's important to kind of learn about this enzyme and what it's all about. This enzyme is measurable in the blood in terms of its concentration, as well as it can be assessed through its activity, because it catalyzes the cleavage of oxidized LDL and yields products that injure the endothelium. And so when cholesterol is deposited in the subendothelial space, the oxidized LDL is converted to lysophosphatidylcholine plus oxidized free fatty acids, and that helps drive the atherosclerotic process. That's been well shown. So Lp(PLA2) anatomically is really one of our best measures of the progression or the burden of atherosclerosis as it's progressing over time. And there are very good anatomic studies suggesting and showing that actually the enzyme is present at the site of very dense atheroma that has just ruptured and caused a fatal myocardial infarction. So everybody in this slide has had a fatal myocardial infarction. And you can see from control individuals to those who just have thin-capped fibroatheroma to actually a plaque rupture, there's a graded increase in the staining of lipoprotein-associated phospholipase A2. And this is just enough that shows up on staining. It's thought to actually be universally present in ruptured plaques, but there's no other measurable substance in blood that is so readily identifiable anatomically in the plaque as phospholipase-associated A2. In fact, the assay is called the plaque assay, and I think it's probably one of the most appropriate tests that we have because of this slide right here. So LPPLA2, or plaque, and the products of this enzymatic activity may play a role in expanding and promoting plaque instability, and additional studies really are warranted, in my view, and I put this out a few years ago, to look at the potential causal role of LPPLA2 in plaque progression and vulnerability. And in fact, it probably does play a causal role. It's probably not a bystander. Here's a schematic of really the source of LPPLA2. It actually comes from circulating macrophages. It's produced, it attaches to LDL particles at the ApoB lipoprotein, and then there's ingress of LDL cholesterol into the subendothelial space, and then the reactions that I mentioned here driving the progression of atherosclerosis. So out of all our measurable factors, this one is most tractable from a biologic perspective. And people have looked at, where in the body produces, is this produced, and so it's measurable in the bloodstream? Well, it turns out the big pools of macrophages are the liver, spleen, the vasculature, and in fact atheroma. And there's been beautiful MRI studies showing that the LPPLA2 is literally coming out of the plaque in blood vessels. So it is very much there at the scene of the crime. Our two assays available have been the ELISA assay, where there's obviously two monoclonal antibodies that basically identify the protein and allow the assessment of fluorescence. And then now the plaque activity assay, and the other speakers will speak to exactly the methodology of how this works. But basically the concept is to provide a substrate and look at the utilization of substrate and give an inference with respect to the activity. So activity is very different than concentration, because activity is not only related to how much of the enzyme is there, but also what is the milieu in the patient of which this enzyme is either more or less active in terms of participation in atherosclerosis. So the clinical impact of the plaque assay has really been assessed over time, and it's one of the most robust tests that we have with respect to evidence. There's been dozens and dozens and dozens of studies showing the concentration of LPPLA2 is independently associated with coronary heart disease, myocardial infarction, cardiovascular death, and it's the only blood test in preventive cardiology that's FDA approved for risk prediction in stroke, which is very important. It's interesting. CRP, none of the others have ever been given an FDA approval for risk prediction for stroke, but in fact the plaque test has. Well, what we know is that the mass or the concentration of the enzyme is related to LDL cholesterol, and there's a correlation, but it's not strong. So a lot of people have said, well, I can just gauge the plaque enzymatic quantity based on the LDL concentration. Not the case. And then the activity is more correlated with LDL cholesterol, but again the correlation is far from perfect. So even though LDL cholesterol is a carrier for LPPLA2, there is some degree of free LPPLA2, and it's also attached to non-LDL particles, primarily IDL and potentially VLDL and HDL. So in fact, there's kind of an enzymatic burden in each person's body that's independent. Okay, and we do know that it changes with treatment. So in this study, this is actually the change in mass with 20 milligrams of rosuvastatin as an example. So people have asked the question, how do you characterize this enzyme? What's the best way to think about it? And the way I think about it is that each one of us has an LDL concentration. And in each one of us, the LDL concentration has with it some type of risk. And it's possible for one person to have an MI at an LDL concentration of 80, and the next person have an MI at LDL concentration of 130. Well, what gives here? The issue is the plaque test gives us an idea of the atherogenicity and the risk of each person's individual LDL level. It's probably the best way to think about it. And in fact, there's enough data to suggest that when the plaque mass or the plaque activity is reduced and it's responsive to treatment, that in fact there actually is risk reduction that's measurable. And that's one of the reasons why this test, in my view, is one of the most tractable tests that we can measure in clinical medicine. I personally have been measuring the concentration assay for over 10 years, and I'm very excited to work with the activity assay as soon as it becomes available in the Baylor lab, which I understand it is. You know, there are lots of studies. Here's a recent study of the activity assay, and this is evaluating patients in the Blick study cohort in Europe, which is a very well-characterized prospective cohort where patients are characterized for myocardial infarction and cardiovascular death, stroke, and TIA, as well as extended cardiovascular endpoints. And you can see the internal consistency. This is per 1 standard deviation unit increase in Lp(a)2. So you can look at the precision in risk prediction of the activity assay. It's really remarkable in terms of what a signal you're given with this assay and cardiovascular risk. Here are the Kaplan-Meier curves, as you can see, over time. And it's a relatively short time horizon. You know, 60 months is 5 years, and you can see really a gradation in terms of cumulative hazard for Lp(a)2. These are the tertile groups for stroke, TIA, and myocardial infarction and death. And this curve right here is for non-cardiovascular death, and you can see there's no separation, so it's very cardiac specific for for cardiovascular events as opposed to infectious or neoplastic-related deaths. And then the study that I think it really kind of pushed this home was called the REGARDS trial. It's the Reasons for Geographic and Racial Differences in Stroke. So it's an NIH-supported trial that's incredibly well-balanced, but they had adjudicated myocardial infarction, coronary revascularization, and coronary heart disease death, a population of 4,500 individuals followed over time. It was nearly perfectly balanced in terms of gender and race, which is very unique in cardiovascular epidemiology. And what you can see here is you can see the 5-year coronary heart disease events differing by race and gender in those individuals above and below a cut point of 225 nanomoles per minute per ml, which is basically the units of the plaque activity assay, with really broad separation in all groups, men, women, white, and black. So unlike, let's say, lipoprotein a, which has no predictive ability in African Americans for some reason, this test pulls through. Unlike extreme differences that we see in lipoprotein subfractions and other things that have been attempted, this test is very internally and externally consistent over time. As a general rule, we want to see lower numbers, okay? And we believe that when we probably get down into the middle 100s, around 150 or so or lower, that in fact we can get to a point where there are 0 events. There were one study from Mayo Clinic and one study from Scandinavia with the previous concentration assay that suggested that you could actually get sufficiently low in Lp(a)2 where in fact 0 cardiovascular events occur. And that's what patients want to hear. Patients want to hear, doctor, am I okay? Am I actually at a situation where I don't have to worry about a heart attack around the corner? And I think this assay plus our risk assessment with lipids and other factors helps. You can see in terms of absolute post-test risk in terms of following patients forward that the plaque activity assay of the lab measures is actually the strongest independent predictor. In renal regards, diabetes and smoking still were greater drivers, but in terms of lab measures, it was a stronger lab predictor than even the residual or treated LDL level. So very important, and again, externally, internally consistent. And to my knowledge, there's never been a study of lipoprotein Lp(a)2 that has shown that it has not been helpful in seeing the future forward for patients. Well, which drugs lower Lp(a)2 levels? And the answer is lipid-related anti-atherosclerotic agents all have an effect on lowering levels. So statins, for sure, by means of lowering LDL concentration, lower the plaque levels. But also niacin, interesting, without lowering as much of the LDL. Fibrates do as well. Omega-3 fatty acids, but the new anti-PCSK9 monoclonal antibodies do lower LPPLA2. Ezetimibe, or a blocker of the Niemann-Pick receptor for cholesterol recycling. And then an interesting class of drugs called azitidone inhibitors, and there's one called darapladib and a related drug called varenicline. And although they reduced plaque levels and plaque activity, they did not influence atherosclerosis. So it's not a perfect story at this point in time, but the proven agents that reduce LDL cholesterol or influence lipids favorable and they have hard outcomes all reduce the plaque assay. So the plaque assay, in my view, can be used as a proxy for the overall disease activity in atherosclerosis, and certainly lower is better. Well, what do guidelines say about it? The most recent ACC guidelines are completely silent on the use of advanced testing. And many of us view the most recent guidelines as being regressive in terms of being less dependent on lab measures. So if we go to the Journal of Clinical Lipidology and the National Lipid Association statement, we have to go back about 4 years to get to a clinical utility of inflammatory markers and advanced lipoprotein testing, advice for an expert panel of lipid specialists. So it's really not a guidelines, but it is a kind of a summary opinion. It's not my opinion, but it's this group. And they put a table up of the advanced markers that you could offer in the lab and where it's suggested that they be used. And there's CRP, LPPLA2, ApoB, the LDL particle number, lipoprotein little a, then HDL or LDL subfractions. So we'll take this first. HDL and LDL subfractions, these are the experts. These are the people who actually order these tests. They're not recommended in a single circumstance, neither in the initial assessment or on treatment management decisions. LPPLA2 got a yellow to be considered in beyond low risk in all other individuals for the initial assessment, but it did not get a recommendation for the on-treatment decisions. And I personally don't agree with this because I do measure it for patients who are currently being treated, but I do follow this and I do get it up front in all individuals as I get CRP, ApoB, and I do get the LDL particle number as part of a profile that we get at the Baylor Preventive Cardiology program. So we're with pretty much the guidelines, but the idea here is that there's sufficient evidence that in fact down this line LPPLA2 is helpful in terms of informing patients about their risk based on their existing risk profile, family history, and recurrent events, probably family history being the one that drives most of these consultations. So to finish and conclude, and hopefully keep us on time, LPPLA2 plays a role in the initiation and progression of atherosclerosis. Epidemiologic evidence is strong for added prognostication of cardiovascular events with LPPLA2. The plaque activity test is currently indicated for primary prevention of coronary heart disease, while the plaque ELISA test done at specialty labs is indicated, its indications include both coronary heart disease and ischemic stroke for both primary and secondary prevention. So as the activity assay rolls out, and there's more research with it, we expect it to get the broad indications that the ELISA assay has, and that anti-atherosclerotic lipid-lowering agents reduce LPPLA2 activity. However, there's insufficient evidence to use the test results to select drugs or titrate doses at this time. It is kind of a global index of where we are in our treatment of atherosclerosis, but I do have to kind of temper my enthusiasm with where we are with the evidence as well as the physician recommendations. So I'll stop here, and we're going to take questions, Rob, or panel?
I think we're going to have plenty of time for a panel later, so we'll go ahead and get through the talks. Thank you very much. Well, thank you very much, Dr. McCullough, for that talk. As I was saying, we'll have plenty of time for questions during the panel discussion. So please join me in jotting down any questions you have for Dr. McCullough or the rest of the panel, and I think there'll be great substrate for a wonderful discussion. Next, I'd like to introduce Dr. Leslie Donato. Leslie got her PhD in biochemistry from Cornell University. After this basic training, she then joined the postdoc training fellowship in laboratory medicine at the Mayo Clinic. She remains at the Mayo Clinic as a faculty member, where she is co-director of cardiovascular laboratory medicine, and is also very active in the hospital clinical laboratory there, as well as in point-of-care testing. That's in the Department of Laboratory Medicine and Pathology, again at the Mayo Clinic. Dr. Donato's main interests are analytical and clinical utility of novel cardiac biomarkers, and she's at an ideal institution to pursue this interest, I believe. And this morning she's going to speak with us about measuring LP-PLA2, comparing the mass assay to the activity assay. Leslie?
Thanks for attending this morning. It's nice to see you all here. So Dr. McCullough's talk was a perfect introduction to what I wanted to discuss as well, and hopefully I'll give you a little bit of clinical background, but of course he's more of the expert in this area, but hopefully my comments will just supplement the things that he has said. And really what I want to talk mostly about is comparing the two available assays for measuring LP-PLA2 that are available now clinically. So just as a primer, again, a reminder, LP-PLA2 is an inflammatory marker that's produced highly in vascular intima and specifically in the plaques themselves. And so we can measure that some of it circulates bound to lipoproteins, and we can measure that in circulation. So, and of course, patients with higher plaque in circulation are at higher risk for events. And so I just want to emphasize that LP-PLA2 is an enzyme, and this was highlighted in the previous talk as well, but it does take oxidized phospholipids and hydrolyzes them into proatherogenic molecules. And these are specifically oxidized fatty acids and lysophosphatidylcholine. And that'll become important when we talk about the enzyme activity assay. So the two clinically available tests for measuring LP-PLA2, as have been already presented before, are we can measure the concentration, the amount of protein in circulation, but we can also measure the enzyme activity, and that's the assay that we're focusing on today. But it's interesting that both of these assays are used to assess the risk of future cardiovascular events. I just want to take one slide just to say how unique this is actually in clinical medicine. Usually we pick one strategy or the other for measuring a protein, an enzyme, but in this case we have two different options. There are examples of proteins that we measure in the laboratory by two different methods, but it's usually for two different clinical indications. So, for example, fibrinogen, standard coagulation assay, but we can also measure the enzyme concentration, or the concentration of this protein for other indications such as the cardiovascular risk marker. Or creatine kinase, of course, we can measure total enzyme activity here for various muscle diseases, or we can measure, of course, the specific isotype CKMB that has really fallen out of favor but used to be used highly for cardiac marker. So in this case, we have two different assays that actually measure LP-PLA2 for the same clinical indication, and it has been described before in the previous talk that we have this ELISA assay that uses, it's a standard ELISA assay as laboratorians we're probably aware of. So two monoclonal antibodies, microtiter plate with a capture antibody and a detection antibody, and then we measure that detection antibody using a substrate and read the color detection. Now the new activity assay measures the enzyme activity using a substrate for that enzyme. In this case, a derivatized phosphatidylcholine that, when it's cleaved, it actually produces a colored product at the end that can be measured, and so we measure the rate of that enzymatic reaction by monitoring the production of the color after the cleavage. Now, the concentration assay was FDA approved in 2003, and the activity assay was just recently FDA approved at the end of 2014. I just want to take just a note about the nomenclature here. It's certainly, I use it myself, and it's certainly pervasive in the literature, calling this concentration assay the term mass assay. But it's interesting, that's kind of a misnomer, of course, because the protein size doesn't change from person to person, so it's not really the mass that changes. What we're talking about is the concentration of the protein, of course. And so I'll try to use the term concentration as I talk, but I may slip and say the mass assay because it is so pervasive. So lots of data has been shown before. I just show you a few slides showing you the utility. This is actually the first study showing that LPPLA2 was associated with, or is associated with, coronary heart disease risk from the WASCOP studies. And what's interesting in this study, I find, and this is a comparison of CRP, a very well-established inflammatory marker that's been shown to identify persons at risk for future events, and is so well accepted that it's actually incorporated into, well, it's one of the few markers that's advocated in the most recent guidelines for re-establishing or assessing patients who are certainly at intermediate risk for determining treatment strategies, but it's also included in various calculators, such as the Reynolds risk score that's out there as well. So if we compare the predictive ability of CRP and LPPLA2 in this study, you can see in the red data with increasing quintiles of concentration, both assays or both analytes are predictive. What I find interesting, at least in this study, is showing you that when you put it in multivariate analysis, looking at additional factors of risk, some of that predictive ability of CRP is actually mitigated in these models, whereas the risk prediction of LPPLA2 actually stays pretty consistent in this particular model. So this leads to the fact, or at least to the idea, that LPPLA2 may be a little bit more specific for cardiovascular-related risk prediction than the more systemic inflammatory marker, that's CRP. And that was for coronary heart disease. And here's what was alluded to earlier, is that it is predictive for stroke. Some studies actually show that the risk prediction it could be even the stroke that's most driving that risk prediction. But as you can see here, that it's independently associated and additive to the information that we get, the risk prediction that we get from high-sensitivity CRP. And again, just showing you the data from the REGARD study that's been shown before. This is actually the figure that's in the package insert. If you if you've seen this, that the risk prediction of coronary heart disease using the new plaque activity assay is evident using a cutoff of 225 nanomoles per minute per mil. Now, I've been talking mostly about primary prevention, and it is, I just want to take just one slide just to show that it is predictive in secondary prevention as well. A variety of different studies have shown that, and that's been alluded to and most heavily studied in using the concentration assay, but there are studies certainly coming out, and I think it will be well accepted that the LPPLA2 activity assay can be clinically useful in this arena as well. Now, one meta-analysis that's really nice when you're trying to compare the two assays against each other is this meta-analysis in Lancet that was published several years ago that looks at 32 separate studies and nicely separates the data depending on whether which assay was used. So either the activity of the enzyme was measured or the concentration was measured. By several different assays within each class, but it's nice that it's separated by either activity or mass here. And what you can see is that the risk ratio, again, this is per one standard deviation increase in either mass or sorry, I did it again, so concentration or activity. The risk prediction of both assays is actually fairly similar to each other. And that's important for deciding, well, it's important for the utility, using the utility, but proving the utility of this marker, but can cause confusion for physicians and laboratorians to decide which assay to use, and I'll get into what we think. In a fully adjusted model, you can see that LPPLA2 activity and concentration here are very similar in risk ratios for coronary heart disease and compare favorably to others such as systolic blood pressure and even non-HDL cholesterol. So getting to the heart of the talk here, we have the concentration assay and we have the activity assay. Question that we can get is, well, are they interchangeable? Of course, the simple answer is no, and that's because we're measuring two fundamentally different aspects of this protein. We're measuring the concentration, which is reported in nanograms per mil, and the other assay is the activity assay, which measures in nanomoles per minute per mil for enzyme activity. So, of course, the numbers that you get from one assay to the other are not going to be identical. So that's a given and understandable. But the real question we're asking here is, what about concordance of the data? If you have patients that are measured by both assays, what's the risk prediction utility of both of these assays? So there are several studies that have looked at this. One of the nicest and clearly defined ones was published in 2007 using the Malmo diet and cancer study. This is, again, a primary prevention cohort, no diabetes or history of cardiovascular disease. Correlation coefficient in this group of patients, 0.57. And what they did nicely here is stratified patients into tertiles based on LPPLA2 activity or LPPLA2 concentration here in the bottom table. And what we can see is that highlighted in green, hope that's showing up for you, are the concordant data. So patients who are either both low in concentration and low in activity, or high in concentration and high in activity. Identifying essentially this concordance being that both assays would identify the same population as being at low risk and high risk. So if you add up this data, it's a little over 50% of the population would be concordant by both assays. But what's interesting is that in each highest quartile, so for example, the highest quartile for LPPLA2 activity, about 40% of those individuals are categorized as either low or middle tertile by the concentration assay, and vice versa. About 40% of the top tertile of patients who have high concentration of LPPLA2 have actually low or middle tertile of activity. So there is a significant portion of discordance here, and that's when you look at an entire cohort, meta-analysis of the cohorts. This is the same Lancet publication that I showed before. That, again, you see a correlation between the activity and the concentration assay, and it looks pretty uniform looking at just the means, but that can be, the actual data is hidden in the means here, of course. One side note here I do want to say is that it is known that LPPLA2 is higher in men versus women. That hasn't really borne out in clinical studies with cutoffs, but it could be something that we may look at in the future. But when we look at the actual spread of data, this is a separate data set here, looking at post-ACS patients. You can see that there's really quite a bit of heterogeneity. Again, the general trend, patients with increasing concentration have increasing activity, but there's a lot of variability there and certainly a lot of discordant patients. So that leaves us with a conundrum. We have two methods that obviously in clinical, the published studies have shown to be predictive of risk. And for the physicians and laboratorians in the room, the question is, of course, which one do I choose? The answer may be the activity assay, and that's what we've chosen at Mayo Clinic to implement. The reasons, I'll give you several reasons, and they're listed here. So for practicality, there could be some clinical reasons, and finally some analytical reasons. Practicality is pretty straightforward. We have the two assays. We have the concentration assay, which is that ELISA assay. It's certainly a very manual process. It takes manual pipetting from your technologist in the laboratory. There's washing steps, there's reading steps, and these are pretty manual process, and oftentimes samples are sampled in duplicate, looking for concordance between those results, and it's usually not offered in-house because of this manual process, this highly manual process, and usually is a send-out test. The activity assay offers the advantage that it can be run on an automated chemistry platform, so it can be run with your routine chemistry testing, and so it's more easily brought up in a home laboratory on your automated chemistry platform. So the second reason why the activity may be the test of choice would be a couple of different clinical reasons. The first may be that it tracks with the LPPLA2 inhibitor that we learned about from Dr. McCullough. This may be less of a clinical reason because of the negative clinical trials that have been recently published, and I'll talk to you about that. There's also some studies that suggest that the activity assay may be a better predictor. I've shown you a lot of studies that shown that they really track very well as far as risk prediction, but of course you can find discordant studies out there, and I'll show you some examples of those. So let's start with the inhibitor of LPPLA2, which was presented before. The idea here is that the small molecule inhibitor will actually inhibit the enzyme activity such that the enzyme is not producing those pro-atherogenic moieties from oxidized phospholipids. And so the idea is that if you can inhibit the enzyme, you inhibit the atherosclerotic process and lower eventual events. It's been shown that when patients are treated with the inhibitor for LPPLA2, that the activity, of course, of the enzyme also is decreased. And this is in a dose-dependent manner here, as shown in this slide. Patients treated with increasing concentrations of the inhibitor show a corresponding decrease in LPPLA2 activity. However, the clinical usefulness of this was kind of dampered by the two, as you're probably well aware, two phase 3 clinical trials that using this inhibitor in one population in stable coronary heart disease, the other with ACS. Actually, both trials failed for their primary endpoint that daraplamin did not reduce major coronary events versus placebo. So the idea is that LPPLA2, while I think there is more study to be done in this area, it's likely that it's more of a biomarker of vascular inflammation rather than a causal risk factor. But of course, I think there's more investigation that has to be done in this arena. The second clinical reason that the activity may be of benefit over the concentration assay is that there are some studies that show that the activity is actually more predictive than the concentration. So that same Malmo diet and cancer study that I showed you before, looking at the discordant populations, also looked at their risk prediction. So in this particular study, the LPPLA2 activity assay in a multivariate analysis was predictive of future events, whereas the LPPLA2 concentration assay was not. Both were predictive in a univariate analysis, but with multivariate analysis, the concentration actually fell out of significance. And then in a secondary prevention cohort, this is patient population at least 30 days post-ACS. The activity assay, as shown in the graph here, shows an increased hazard ratio with increasing quintile of LPPLA2 activity, whereas in this particular study, again, LPPLA2 concentration was not significantly associated when adjusted for other risk markers. So those are the clinical reasons. The last reason I want to touch on is an analytical reason. that you may not be aware of. The concentration assay, we've shown, this is data from Mayo Clinic now, shown several years ago that samples that are not processed immediately, actually, you can see in the chart here that if they're not processed immediately, you can have actually an increase in the readout from the concentration assay depending on how long the sample is stored. So, excuse me. It might be hard to see with the small font here, but the pink data is samples stored at refrigerant concentration for up to 4 days. The blue data is samples stored at frozen at -20 for up to 4 days, and then the yellow data are samples stored at -70 up to 4 days. So what you can see is that if samples aren't tested until 3 or 4 days post collection, that the concentration can be elevated. And this obviously affects situations such as send-out testing, add-on testing, if a physician's already ordered a lipid panel and then a couple of days later they get the results and they want to know the concentration, that can affect those results. And then, of course, for frozen study cohorts that physicians or researchers would like to test later. So in our internal studies, I won't show you the actual graphs here because it isn't published yet, but the bottom line is that the average change, percent change in LPPLA2 activity is essentially unchanged in conditions of refrigerant frozen storage, and we've tested this up to 30 days now. So lastly, I just want to touch on interpreting previous studies using the concentration assay because of the data that I just showed you, is that sample processing of samples in published studies maybe influence the concentration results. So essentially, it actually puts at disadvantage those samples that were actually processed and tested rapidly, so that in some patient cohorts or some individual samples, the values may never reach the values advocated to define risk just because of sample processing. So while it's certainly clear that elevated concentrations of LPPLA2 comport higher risk in patients, definitely some cautions are warranted for published cutoffs and risk categories using the concentration assay. But again, the activity assay doesn't have these limitations, and certainly it's much more analytically stable in our opinion. So in conclusion, the LPPLA2 activity and concentration both predict risk of future events, but the LPPLA2 activity may be the optimal choice for risk detection because of several reasons: ease of use, as well as clinical and analytical reasons as well. So, thank you very much.
Well, thank you very much, Dr. Donato, for a very clear talk. And now it is my distinct pleasure to introduce my colleague, Dr. Ken Blick. Ken is a professor of pathology and directs several laboratories at the University of Oklahoma School of Medicine and the OU Medical Center. He is indeed a fixture in their clinical laboratory medicine group. Ken got his PhD and did a postdoctoral fellowship at University of Kentucky, where he also remained to do the postdoc training fellowship in laboratory medicine. Ken's professional home has been AACC. He's been very active in leadership roles within the organization. He is a current chair of the Texas section, has been very active in the point of care division, and actually founded the Laboratory Information Systems division. Ken is a superb educator. He speaks on a variety of topics, including informatics, automation, and also cardiac marker testing. Ken?
Thank you very much, Rob. And you know, being a fixture is not a bad idea when you're looking for employment. You know, I was trying to come up with a short title here, and as you can see, I fail miserably. But what we've got here, I think, is a pretty exciting presentation in terms of data. We're going to show you a lot of data that we've generated evaluating the activity test, and I think you're going to be favorably impressed that this test is now doable. You know, we want to test, it's great to have these tests that you hear about, but you want to have something that you can take home and set up in your laboratory with great success, and I think that's the message I want to deliver today. Of course, you've heard that this is a great test. It has great sensitivity, and it's new and exciting, and in fact, the activity test has only been available since December of last year, so it's a brand new test, very exciting. And you've heard from the previous two speakers that the test has great clinical utility. What I'm going to focus on is the fact that we can harmonize, or at least start the process of harmonization. So irrespective of where the test is done, any clinical laboratory in your city perhaps, you'll get essentially the same results. And that'll really help the clinicians that are seeing patients in different hospitals in a community like mine in Oklahoma City. So we have an abstract and we have a paper that's been submitted, and the abstract points out that the test has a normal range, like all lab tests pretty much, and the normal range runs about 84 to 303. The interesting thing about this, though, the healthy volunteers that we had in this study, about 20% of them had values above the cut point for risk, the 225 nanomole cut point. And so just trying to find a normal population in the U.S. that don't have a lot of risk for coronary vascular disease is pretty difficult. The conclusion on this abstract is we're saying here that you can rely on the activity results regardless of the laboratory where the test is performed. That's a pretty bold claim. I can't think of many lab tests where we can say no matter where the test is performed, you get essentially the same result. Well, clearly we're measuring the activity here. The beauty of that is all of our chemistry analyzers are designed to measure activity. We've got a nitrophenol substrate here. We know the molar absorptivity. We could even run the assay without a calibrator, just use Beer's law to calculate the result. So we're pretty excited about being able to do the assay. But how do you come up with an assay that's calibrated in a way where you can get the same results in different laboratories? And so what we're presenting here is you can use a recombinant calibrator, a PLA2 calibrator, and you can literally standardize and harmonize the assay between laboratories. And again, that's a bold claim. Now, you know, we chemists, we like molecules, and so what we've got here is an actual chemical reaction going on in the atheroma found in the intimal area of the artery. And we have this oxidized LDL, which of course we've known for years is a bad guy. But when you have this enzyme breaking this thing down into pro-inflammatory markers and apoptotic markers where we've got apoptosis, we have all of this going on in the intimal area of the artery, a real problem. And as that milieu of chemicals and cellular debris expands in that intimal area, we thin out the fibrous cap. And then we have the release of these thrombotic factors that actually cause a clot to form. Now, we've been measuring all of these molecules over the years, but we haven't been measuring an activity molecule that tells us actually about the thinning out of the fibrous cap. So that's pretty exciting. We'll be able perhaps to identify those patients that are at risk for thrombus formation with the leakage of these thrombotic factors into the area here of the blood and getting a clot forming. So very exciting. Anytime you do an enzyme measurement, of course, you have to have standardization. As you heard, there's only 2 assays where we can actually do this, FDA approved. And of course, here we're talking about the activity assay. So how do you evaluate and come up with the data to show that you've got accuracy and precision regardless of the laboratory or the instrument that you use to measure this plaque activity? Well, this is sort of the study that we are showing here. The first study that we show here shows a normal range study, And you can see here it's a non-parametric distribution. We don't have Gaussian distribution, and there is a skew to the right. But you can see the cutoff on the low end is about 84 nanomoles of activity, and then up on the upper end we get 97.5 at around 303 nanomoles per minute, per milliliter. And so this is pretty exciting. We've got a nice normal range. There is some difference, as you heard, between men and women, but for the most part we're going with one normal range. The other thing that's kind of interesting, and you heard some about this, the molecule in terms of its activity is pretty stable. Even at room temperature, in this study that we've been able to do, we've been able to show that the molecule is pretty stable if you centrifuge it straight way. And if you start at -70, for the researchers in the room, you can get great stability over a long period of time. And so I'm thinking for the studies that are going to show that this molecule perhaps is more efficacious than we think now in predicting coronary vascular disease, I'm thinking that this storage study here is quite helpful. The other thing we've been able to show is the precision of the assay between 3 different laboratories being in the range within lab precision, being about 2%. Now, the beauty of this is when a clinician like Dr. McCullough sees a change in the result between testing, he can be reasonably assured that the change is actually going on in the patient and not something going on in the laboratory. So we want a really precise test here in these various laboratories doing this test, and it looks like the test is set up is quite precise. Now, this is probably a slide most of us have never seen, where you've taken an assay, and in this case a kit assay, and run it on we have 12 to 13 instruments, counting the reference instrument here, which is the Beckman-Coulter AU400. Comparing all of these other instruments to that instrument and running this method, we get essentially no difference in the results. We can accept the null hypothesis that there's not much difference between the assay, regardless of which laboratory you run the assay in. Very exciting. I don't think I've ever seen any assay that shows this kind of correlation between different laboratories. Well, what's the secret sauce here? Well, it turns out that it's using this recombinant calibrator. Here's 2 different lots. The Diadexis people tested, lot A and lot B, without calibration, and you can see very clearly here on this line here, just using the OD to calculate the results, and the open circles show no calibration, you can see you get an 18% or so error, in this case proportional error, between the 2 lots. Then if you take those same 2 lots, however, and standardize them using this recombinant calibrator, we get almost a 1 slope, essentially, again, a null hypothesis. There is no difference between these 2 lots. Well, for sure, if you want to be working with a vendor, you want to have a vendor that sends you reagents that work just the same this month as they did last month. Here's an interesting study, too. We can correlate testing, for example, in EDTA plasma versus serum here, and notice essentially here we get a slope of 1. So, and you heard the problem, of course, of adding on tests. We wouldn't want to add on a test on an unspun CBC sample collected in EDTA, but if that sample was spun and separated pretty rapidly, we could actually perhaps consider adding it on. We're storing our serum now in a refrigerated stockyard on our automation system, so we could certainly add it on to serum. And it turns out we have similar results on lithium heparinized plasma. We did linearity studies here, and the impressive thing here is we have really solid linearity between 3 different lots, and the assay appears to be quite linear between 10 and 400. Actually a little less than 400, kind of like 380 or something like that, but certainly well above the 225 cutoff and the high end of the normal values that we reported, being around 300. So we have an assay where you're not going to have to do a lot of dilutions for the most part, and it's got good sensitivity on the low end, certainly in the 10 nanomole region. What about interferences? Well, it turns out we can run almost any kind of sample, even samples collected with a serum separator, getting good slopes here again, almost perfect correlation. And, of course, the y-intercepts we're extrapolating to get those. So I'm paying more attention to the slopes. And, again, quite nice results regardless of the kind of specimen selected. Again, rather robust and a good thing to see. Looking for interferences, endogenous interferences, we've tested that, and this is, again, going to be published. We're seeing very few interferences from the typical things we suspect for interference for this kind of assay. And then, of course, the drugs, the exogenous interferences that we worry about, we've tested out some of the more common drugs here and not seeing any interferences at these levels. So very, very robust. And as you can see, it's an assay that we can perform in a variety of different laboratories and in different environments. And so I'm pretty excited that we have a test now that I think we haven't had a new lipid test in a long time that really adds a lot of value. I think this one does, and it has a really good story in that it's involved in plaque stability and inflammation. The pre-analytical processes that we talked about that we usually worry about with storage of samples, for example, do not appear to be significant. Of course, we have to do more studies, but so far that's looking quite good. It looks like we can measure this activity measurement on virtually any automated instrument, or at least the 13 that we've looked at so far. Very exciting, meaning that we can have this assay available in your laboratory. So we're thinking having a standardized, harmonized assay will allow physicians like Dr. McCullough to be confident in the results. Confidence is a big deal, I think, when we're talking about a lab result. And I think we'll be able to correlate what's going on in the patient along with the coronary heart disease outcome studies that follow. I think some of the data that we've been looking at so far is kind of skewed with specimen handling issues and differences in assays. So I think we're going to get a lot better data showing that this marker is a lot more valuable than even the current data suggests. And we're thinking that we're going to get more studies and more support for that, those sorts of studies that show that this activity test can really help us eliminate a lot of the vascular disease that we see. And certainly I know all of us are interested in that. So I think with that I'll close and turn the program back over to Rob.
Well, that was terrific, Ken. I think the type of analytic studies that you and Dr. Donato explained are critical to having confidence in these assays. Well, now it's your turn. Any questions for the group? Please come up to the microphone and identify yourself, and just address the panel, and they'll be happy to give you responses. Maybe I'll start off with the first question, and I'll start it off maybe asking Dr. McCullough. You know, those of us who have been in the field of biomarkers for some time, you know, we've seen a lot of markers come and a lot of markers go, and so most of the ones that go are risk. They have to do with risk, but then the question comes up, well, okay, they're high risk, but what do we do about it? Do you consider the plaque test an actionable value?
Yeah, in my view, and I would have to say that I do differ from the most recent AHA-ACC guidelines panel. I do differ in that you know, the guidelines now suggest that we don't even do repeated measures of LDL, that we simply assess global risk and blindly prescribe statins. Many in the field have felt that those guidelines are regressive and that they don't represent state-of-the-art care. In fact, they represent a minimum base care for maybe centers across the globe, but certainly not here in America. I think the results of this test are actionable in the following way, is that we have statins as a base treatment. We have a third of patients who are statin intolerant or have perceived statin intolerant. We have a brand new class of agents which are monoclonal antibodies, which are going to be very expensive, about $14,600 a year for the monoclonal antibodies. There's going to be a lot of discussion about what else in this patient puts them at higher risk. And we're going to see this coming from payers. I've already been on several payer boards that say, listen, we want to see the case. And so, in fact, I think the ante will be upped for these additional markers of risk. The one that's measured, and we do measure it in each and every one of our patients, is high sensitivity C-reactive protein. C-reactive protein, unlike the plaque test or LPPLA2, CRP is itself not pathogenic. I hope everybody understands this. CRP does not participate in the pathogenesis of atherosclerosis. It is a global risk indicator because it globally integrates many risk factors like diabetes, hypertension, obesity, etc. The plaque test is independent of diabetes, hypertension, obesity, independent of renal function. So it's a much cleaner look at the atherosclerotic process. And I think the only thing that's impaired this test in the past is availability. We've had to send it out, and there's been some assay problems where Ken's pointed out with respect to variation as well as problems with storage over time. The activity assay looks incredibly clean. I know our lab is going to go to it because of the fact that it's going to be generalizable across all the platforms. The thing I didn't realize, and I learned from Ken's talk, is that this test has a great degree of precision, meaning a small change in the test is a real change. And in fact, we don't have that with LDL. Even the calculated LDL, we need to see pretty broad changes before we know there's actually a real change in LDL concentration.
Well, thank you very much for those insights, valuable information. Yes, sir.
Shahram Shahangian from CDC, and I know not very much about this marker. There has been a lot of excitement with high sensitivity CRP, and from what I understand, it is still to be accepted by the U.S. Preventive Services Task Force as a marker for screening of cardiovascular disease. Now, the issue of added utility which comes, there are various markers, another added marker. With the advances on drugs that inhibit the activity, would the panel see the testing being done a great deal to evaluate efficacy of the drug inhibitors vis-a-vis a simple doing of the test for further risk evaluation?
Yeah, well, I'll answer that. I do that in my practice. I know it's not guidelines recommended at this point in time, but it's the only marker that helps integrate the treatment effect. Now, it turns out that anti-atherosclerotic treatments that begin to modify various lipid entities, HDL, LDL, IDL, and VLDL, in fact, those drugs that I put up on the board, there are data behind every single one of those drugs that they influence the plaque activity level. The specific inhibitors of plaque activity that did not influence other lipid fractions had no impact on atherosclerosis, and that's been shown. So it's very interesting that the sum total integration of our anti-atherosclerotic drugs, which each individually have been proven to reduce cardiovascular events, is reflected in the plaque activity level. So I personally ride with the two studies, which I think are very convincing, showing when you get sufficiently low levels of the plaque in the bloodstream, which can be achieved with multi-drug approach, you can get to 0 events over time. 0 events. It was shown in a Mayo Clinic study, and it was shown in a study from Scandinavia. And we can't do that with LDL alone. Even at the low levels of LDL, there's still events because there still is risk out there. And it's really conferred by the enzymatic activity of this enzyme. So.
Dr. Toffeletti.
Thank you. Very good talks. Particularly referring to Leslie's data, but maybe any of you can answer this. You had comparing the mass versus the activity, the concentration versus activity. Mm-hmm. That there were some very clear differences of some low and some high, which should, like I said, very clear differences analytically It would seem to me that the key would be to look at those individual cases to see which one was more correct. Is there any effort to do that, or any comments from any of the panel? About if one showed, I mean, there you got your very clear differences analytically. What about clinically?
Yeah. We don't have the data set to look at that for follow-up. It's something that we're actually very interested in. But what I can tell you is that the issue that we told you, or that I showed you about the analytical stability of the test results in the concentration assay, just puts at a disadvantage the tests that have been performed on samples that are tested immediately. So just because of this, in theory, we think that the activity will be more predictive, but again, we would need to look at that. Great question.
You know, people have scratched their heads regarding this issue of concordance or lack of concordance. But when you think about it, it's an enzyme. So some of it is actually free in plasma. Some is more or less tightly bound to ApoB on the LDL particle, as well as VLDL particles and IDL particles. And because the enzyme is existing in plasma in these different states, it's not hard to imagine that there'll be individual differences and that the plaque activity will be a much better representation of really the atherosclerotic disease progression than the concentration alone. So it's very interesting, but the fact there's discordance, in my view, is a good thing because it gives us important insights, it gives us new research angles, and I'm very excited with these new injectable monoclonal antibodies, which do lower the plaque activity, and that's been shown in a recent study. The bottom line is, with these new injectable agents, I think you're going to see a lot of interest in going beyond the lipid profile. And for the first time, we have something available in the central labs that you guys really administer that's going to be very useful in preventive cardiology.
Dr. Toffolati, I think it's very clear that in some of those patients, like you point out, we're measuring something different. And with the mass versus the activity assay. And what I'm thinking is, just as Dr. McCullough said, as this assay gets out there and becomes more available, we're going to see a lot of studies showing better explanations as to why we have these kinds of discrepancies. And so I'm thinking having the assay out there and having it, as you see, pretty much harmonized between laboratories, we may even come up with better treatments to lower plaque activity, things that we don't even know about now. We've done the standards, but with this available, I'm sure we're going to come up with things perhaps that will lower the activity and really reduce risk in a very special way that'll save a lot of lives.
Reminded me of what Dr. McCullough said about that this actually participates in the pathologic process itself,
right?
Rather than just being a pure marker. So it would logically make sense that the activity would be better.
Yeah, I mean, it's physically, I showed you a couple different ways, one using NMR technology and yet one using just basic histopathology. The enzyme is physically in atherosclerosis and physically participating. It's the only marker outside of probably LDL itself that's actually physically at the scene of the crime. You can't show similar histopathologic slides or even using animal studies for CRP. You can't show it with myeloperoxidase. You can't show it with other advanced markers. So because it is proven to be pathogenic in atherosclerosis, there's a belief, Rob, that this isn't just a passing thing. It's not like a marker that has popularity for a while, like maybe Donald Trump or what have you, and then goes away. That, in fact, I've personally been measuring this for over 10 years in my practice, and I found it extremely useful. I think there's a lot of precision, and I'm excited to move on to, I think Ken's convinced me of, and Leslie has as well, that the new test is a better test. It's a better test, and in your hands now, I think it's going to be much more available, and it's going to be interpretable across hospitals and centers worldwide.
Yeah, and it's interesting, as I listened and learned from the discussion today, certainly activity would be much closer to function than is a concentration or a mass assay. So that may be it. To ask a very nutsy-boltsy question about pre-analytic variation, I think, Dr. Donato, you did a nice job in discussing that, but can you compare the pre-analytic stringency for the concentration assay. I keep wanting to say mass myself. Concentration assay versus the activity assay?
Yeah, we and I think Ken presented this data as well, that it's really quite stable. The activity, we found similar data to what Ken presented. There was some lot-to-lot variability in the concentration assay that we found in previous studies. That's really not the case in the activity assay. The stability of the analyte really rock solid from day-to-day variability. We showed same CVs, very, very stable. And that's really important. And freeze thaws, you can do multiple freeze thaws and get the same activity. We were involved in evaluating the assay in a pre-FDA format for several years before the FDA approved it. We actually had a stored sample bank that we tested on one of our first lots of pre-FDA approved reagent. We retested those same exact samples after the FDA submission or after the FDA approval. The samples were stored for 3 years. We got exactly the same results. So really very analytically robust assay. So and that's really great for not only current patient care testing for patients that you see now, but it was really important for evaluating studies to be able to be confident in frozen samples, that cohorts that are already collected on a variety of different samples sets in clinical research, that now we can be confident in their activity assay results on those frozen samples. So yeah, I'm very, very confident in the assay.
So is it true that you Mayo Clinic no longer does the old assay now, so you've moved to the new one, so.
We actually we took the concentration assay down several years ago because of the data I showed you, and just 2 weeks ago we have it up in our reference lab. So it's up in orderable now.
So it'll be the standard.
Okay. And it really is actually the standard of care. I wanted to talk about incorporating it into clinical practice. You may be aware in the audience, but Mayo Clinic physicians, cardiologists in particular, are very conservative. They really don't embrace advanced cardiac markers in general. This is actually one test that they've been asking for years now. And so they're really excited. They're actually going to incorporate it into their standard order sets for all patients who are seen in preventive cardiology. So, not only are we excited about it analytically in the laboratory, but our clinical practice is excited about it and are going to utilize it on an everyday basis.
Based on Leslie's observation, though, I would be reluctant to centrifuge a CBC sample that's been sitting around at room temperature in the lab and doing an add-on test for this. So I think probably leaving it on the cells for an extended period of time is not indicated, based on your observations.
So Ken, what would you call extended? 4 hours, 8 hours, 2 hours?
Well, that's a study we want to do. I've talked about that because I think that situation comes up where we want to centrifuge the CBC sample and add on things like hemoglobin A1C. I just did an article on that, but I'd like to know what the options are there. If it's been around in the lab for 3 hours and it's still stable, it would be nice to be able to add that on, because collecting another sample is always a big issue. So
we look forward to that characterization from you, Ken,
right,
in these days. The other thing is the flexibility with sample type. You mentioned it all. Basically the green, the red, and the purple can all be run. I don't know, folks. Do you have any more questions? More? Yes, sir.
I have a question because I aware of another biomarker they call the secreted PLA2. I want to know clinically, are these two markers similar or correlated? The ASPLA2.
So I guess the question is there data that compares secretin and plaque?
Right, you're talking about the secretory phospholipases as opposed to lipoprotein associated?
Yeah.
So there's a whole family of lipoprotein phospholipases out there. There's a family of secreted phospholipases that are very kind of a general utility set of enzymes. They don't correlate very well at all with lipoprotein-associated phospholipase, and it looks like they don't participate at all in atherosclerosis. That's been sufficiently shown. So you can't find secretory phospholipases involved in atherosclerosis in the plaque, and they're actually more of a GI origin. They were addressed in a clinical trial of using a drug called varispladib, because you can actually specifically inhibit them, and that failed. In fact, that actually inhibiting the secretory phospholipases had toxicity to it, and the trial with varispladib was stopped early. But there seems to be something unique about phospholipase-associated phospholipase A2 and modifying it in the setting of modifying the other lipid entities that leads to improved outcomes. And I think it's unlocking a frustration we've had in cardiology that when we broadly apply, for instance, if we use statins and we treat to an LDL concentration of 70, and then we broadly apply niacin, it looks like it doesn't work. Or we broadly apply ezetimibe, it looks like it barely works. Or we broadly apply fibric acid derivatives. Having said that, if you throw lipoprotein-associated phospholipase A2 in this personalization approach and you look at the data that exists, those individuals who are treated in the multi-drug environment who achieve low levels of LPA-PLA2, typically less than 160. I think with the new assay it's going to be 160 or 150. Below that, it's the only insurance that we know with data that we can tell patients that they're going to be event-free. It's very important. I think if you have atherosclerosis, I had dinner last night with a really nice doctor who's in charge of one of our labs, and he just had an LAD stent put in, at 95% LAD, and his young guy, younger than me, and he basically asked me, he goes, am I going to be event-free or not? I said, everything I know about this literature is you can't just look at the lipid profile and look somebody in the eye and tell them they're going to be event-free. We need advanced markers. I have a lady who just emailed me this morning. Her LDL concentration is 70. And she's so frustrated. She's just had another stent put in, and she's desperate. And her plaque number is something like 290 or whatever. She's rocking on that level. She's very, very active. And I told her, I said, everything I know is your atherosclerosis is very active, and we need to quell it down, probably with multiple drugs. By the way, the plaque test is also the only test that's responsive to the anti-atherosclerotic activity of omega-3 fatty acids. And we have 2 new market entries there. People have been frustrated with that. Who takes fish oil and who doesn't? Where do we use the prescription versus the over-the-counter? This is the only test that's kind of responsive to it. So I think we have a lot to learn in preventive cardiology, and I'm really glad to hear that I'm not the only one out there, that the whole Mayo group and others are going to go with this, because I think it really is a breakthrough. We're going to see a lot more studies with it.
Good morning. I'd like to ask if there is any recommendation for the patient before testing, like fasting, medications, anything that will interfere?
No, not that we know of. It doesn't need to be, the patient does not need to be fasting, and there's no, to my knowledge, no known medical interference.
So really the pre-analytical phase seems to be very straightforward with this test.
One thing that we're thinking about, however, is making this available as a reflex test on our traditional lipid profile. And of course, you want to have the patient fasting for a lipid profile. So that's what I'm thinking in our laboratory. We'd like to have this available. I'd like to hear what Dr. McCullough thinks about that, but I would like to have it available as an add-on, maybe not making it right away part of the profile, but having it available so that we can add it on. We have an automated system. We'll have the system there to retrieve it out of the stockyard, and we can do that automatically on our chemistry analyzer without involving any of the techs. So I'm thinking in our lab probably we will still go with fasting samples for the lipid panels and then have it available as an add-on. Because it does look like it works on lithium heparin. I might want to do some internal studies on that just to prove it, but that's a sample we currently use most commonly.
Yeah, I think that's a fair point. Because we get it in time, at the same time we get the lipid profile, the patients are fasting anyway, although the fasting state doesn't influence the activity. To me, the big thing is that it's not influenced by obesity, renal function. It's not, CRP is a very confounded. Sometimes I see sky-high CRPs. We published on this in an obesity clinic where if you want to look at CRPs over 10, I mean, it's in the patients with significant obesity or morbid obesity. Here, trying to gauge atherosclerotic risk in an obese patient is terribly difficult. And the plaque test is very clean. It's absolutely not influenced by body weight at all. It's produced by macrophages. These macrophages are resident there in the atheroma. It's physically being produced in atherosclerotic material. So it's a very good index of anatomically what's there.
So one of the things that I think I've learned this morning is that the activity assay has a number of advantages, not only analytical but also clinical. As I listened to Leslie's talk, though, it seemed that, and this was related to Dr. Toffolides, it seemed to flatten out at the top and maybe at the bottom with the concentration assays where it was more of a straight line. Do you think that we've talked a lot about the mass assay and how, issues with it, but it has been over time a pretty darn good test, and there's been a lot of data on it. Do you think the data are conservative? Or in other words, if the activity assay had been run on those samples, do you think it would even be better? Or is that sort of a fair, what do you guys think about that?
Yeah, it could be a fair estimation or extrapolation of what you might see using the activity assay. We just don't know. I can't remember who I was talking to. Someone said it's with the analytical issues of the concentration assay and still seeing all this great data coming out showing the predictive ability, it's a darn good molecule a protein to test. And so having a more analytically robust assay to measure that same protein by measuring the activity in this case, I think it's potentially, it could be even more predictive than we think.
There's another way to approach that, though, just quantitatively looking at risk. So in epidemiology, we have a couple ways to do it. A lot of times we just do quantiles, and we assign the lowest group as the referent group, and we look at quantiles, whether it be tertiles or quartiles, and that's one way to do it. But you saw a couple slides where the investigators chose to do it by standard deviation of risk. And if you actually look at that, by standard deviation of risk, the activity assay is much more powerful as a risk predictor per standard deviation.
Right.
So, I mean, that kind of tells you something. That gets to your question of when you start to range up, will this test range up and give us a better window of risk through the whole spectrum of values? The answer looks like yes, and better so than the mass assay.
Right. So not only, so it really a clinical advantage if that turns out to be the case. Well, you all have been a wonderful audience. It's about 8:40 right now. I guess last call for questions, but if there are no more, we'll go ahead and end the session. I'd like to thank our speakers today for excellent talks and, most importantly, for ending on time. But anyhow, thank you very much, and I hope you have a great rest of our AACC meeting. Thanks very much.
Yay.